Zimbabweans, Zimbabweans, and anyone watching from across the globe, welcome back to Make Your Mark with SOTZIM, our favorite weekly program where we talk about all things COVID-19. Today, I have got arguably the coolest people on the planet in 2020, scientists, to talk about everything from immunology, virology, right down to vaccines and whatever else we want to pick their brains on. But before we launch, I'm going to hand over to Karen so we can get a quick update on SOTZIM, and then we'll come back and talk science.
So I'll be as quick as I can because I'm sure there's going to be loads of people who've got so much to say, and we're so excited. Thank you to all the panelists for agreeing to be on here. So Solidarity Trust has been quite busy. Our team went to Bulawayo to make sure that we are not only dealing with Harare, and that we also have our other major city involved. Darlington and Nigel Chanakira were up in Bulawayo, and they made some headway and saw some fantastic facilities that require funding for them to also be on board. Harare has seen another facility come on board as well, which is also going to offer 80 beds. St. Anne's, again, we are literally, I keep saying 11th hour, we really are at the 11th hour. They're training. We're hoping to sign the contracts that we've been waiting for, and then we'll be ready to go. Cases in Harare have really picked up in, mostly from imports that have come into the country, which I'm sure you'll hear about. We're a little bit too relaxed. Restaurants were opened this week. I'm happy. I have a restaurant, so I'm happy. But we're having to put in a lot of protocols, and we just need for Zimbabwe to not be too complacent in that it can happen overnight, as what's happened in some other countries, especially as we see in South Africa. So I hope that after today, we're going to be as diligent and disciplined as we possibly can to not take this really horrible pandemic for granted. So
tonight we have got a group of virologists, as I mentioned earlier on, and we've got an immunologist. We have Justin Manassa, Richard Lezels, David Kazenstein, and Tariro Makadzange. All of these are our super scientists who come through with frontline COVID experience in various guises. And I really just wanted to pick their brains and keep declaring that I've got so much respect for everything that you do, particularly in the season of COVID-19, where the world has been panicking about what this virus means to us, what it means to our lifespan, what it means to our family, loved ones, friends, and what it indeed means to those people on the front lines. So welcome, everybody. Really nice to have you on board. Right, so I'm going to start off by being random, as I like to do, and I would like to ask each and every one of you to please give an elevator pitch of why virology or immunology should be the career of choice to a 16-year-old who might be thinking about their future in medicine or in science. I'll start, if I may, with Tariro. She's got the biggest smile.
Thank you, Mucha, and thanks for the challenging question. I guess my question would be, why not? I think there's nothing more exciting to me than science. One of my fondest memories, and I think one of the things that drove me to do what I do, was as a college student spending the summer at the UZ Medical School. And there was a wonderful microbiologist, her name was Helga, and she would take the students around the wards, and there were these slide rooms at the end of each ward. And I remember the first time I saw a malaria parasite under the microscope with Helga's guidance. And I was just amazed by this, the various life stages, the various life forms. And I thought to myself, this is super cool. I mean, this parasite that's so tiny and sits in a red blood cell and yet does so much to society and has such a huge social impact, economic impact. How can this thing do this? And then she talks about how the antigenic variation of the parasite and how it sort of continuously evades the immune system. And it just sparked an excitement in me. And I then went on to be very interested, first in tropical diseases, studying African sleeping sickness, which was quite interesting. And then going on to graduate school and medical school, etc. So for me, the question became, why not? What else could I be doing then? Sort of looking at exciting parasites and trying to think about how they evade the immune system. So to a 16-year-old, I'd say, find something that excites you and stick with it, and it will keep challenging you, and there'll still be more and more questions ask and answer, and new things will come up. COVID, some of us are HIV researchers, and we're now pivoting to COVID and using some of the same techniques, assays, approaches to asking questions to work on a new problem.
So Terry, my elevator's gone up and down 6 times, which is fantastic. I've stayed captivated in all that time with your pitch. So thank you very much for that. I'm going to move to David, if I may. What's your equivalent?
Take the skills that you have, which I don't, and apply them, which is to say, you can probably do things on cell phones that I struggle for hours. Justin can tell you how thoroughly digitally incompetent I am. Most 16-year-olds these days are far more advanced than I at the use of telecommunications. So I think they should mobilize their peers, and they can usually get a few 100,000 of them together without too much trouble on these various social media platforms. So that's where the future lies, I'm afraid.
Okay, so we've got Teriro, who was inspired by looking through a microscope and understanding the character of malaria and all other tropical diseases. We've got one advocating for the leveraging technology. I'm going to come across to you, Justin. How would you convince a 16-year-old to join the army?
For me, I like viruses more, and they are simple, but they operate in a very complex manner. They affect our lives in many different ways. They are all around us, in our bodies, in the food, in the water that we drink, everywhere. And they've affected how, as human beings, have evolved. So in our genomes, there are a lot of viruses that are existing there that don't cause any disease, that are just there. So for me, that's my fascination, understanding these very non-living organisms that transform and impact us in many, many different ways.
That's very good. Thank you very much for that. And last but not least, I'm coming over to you, please, Richard.
So I'm actually not a virologist. I'm an infectious diseases physician. So I see patients and I link up with virologists like Justin, but Justin will tell you he wouldn't let me in his lab because I would make it in his lab. So I'm safer seeing patients. But to be honest, this pandemic is exemplifying why people should train in medicine and train to be infectious diseases physicians or virologists or anything, because we need them more than ever. And because it's by far the best job in the world. It's the most fascinating branch of medicine because there's always going to be new infectious diseases. And this pandemic is telling us that and showing us that, unfortunately, in a terrible way. So I think all of us on this call are in science and medicine because we love continually learning and we love to learn new things. And that's what science is about, and that's what gets us up in the morning. And hopefully by doing that, we help to deal with things like this pandemic, which are ravaging the world.
Thank you. That's really great context, I think, in just understanding what's motivated you all to go for your career choices. And as COVID-19 has built momentum, laymen like myself will have no idea what to expect from the virus. We're dependent, of course, on science and the studies that you guys are doing behind the scenes to get an understanding of what stands before us. One thing that I've often wondered is what the communication line is from the lab to the front lines. So you quite aptly mentioned that you're the guy in the front line, or you're the physician who's actually dealing physically with patients. But where you've not necessarily been involved in the research and you don't necessarily have first-hand research on the genomic makeup, for instance, of a virus such as COVID, how do you guys communicate and how do you link your thoughts and how do you then know how to take it on and fight it effectively?
So I mean, I think that's part of our job, and that's part of what we try and learn to do is how to collaborate, and that means like doctors, physicians collaborating with scientists, collaborating with the people in the lab that are doing the diagnostic tests and the tests to help them manage their patients. And that's something that we do very well over the years. And Justin can tell you, Justin did his PhD with our group in South Africa. One of the first things that we did, because Justin was stuck in the lab and liked to work away in the lab, one of the first things that we did was took Justin and some of the others in the lab up into one of the clinics in the very rural part of South Africa and gave them a sense of what the clinic was like and what the healthcare workers on the front line were dealing with day in, day out, in terms of the numbers of patients they were seeing, the complexity of it, and really to show the people in the laboratory what the real value of what they are doing in the laboratory is, how it helps people on the front line. And we find that that's a great motivator to the people in the laboratory to know what's happening to the results that they give out, what's happening to the science that they're doing in the laboratory. It's actually having an impact right on the front line. And that thing we continue to do is to make sure that that link is strong and there's a strong connection.
And Justin, do you feel appreciated for what you do behind the scenes? Because I think, we all assume that the glamour is what we see on ER and what we see in Grey's Anatomy and all that sort of stuff. But it's you guys who are kind of really driving change from your science and from your application of it. So tell us what your experiences have been, and if indeed you see directly the value that you're adding, because it's appreciated.
Yes, as a medical lab scientist, I really appreciate working as a team. I remember when I was working with Richard, it was for me a focus mostly on the virus. He always told me that just you're not managing a virus here, you're managing a patient. Because for me, I used to just think about things from a virological perspective. But from Richard's perspective, he was looking at it from a broader perspective. And for COVID and other infectious diseases now, it's even more than a patient, because there are economic implications, there are security implications. So it's no longer just about the virus or the patient, but also about economics and national security. In terms of working with as a medical lab scientist, I think there's always need for communication in both directions between doctors and medical lab scientists. And if that communication is there, the care of the patient is significantly improved, because there are things that sometimes the clinicians might not appreciate from the testing perspective that the lab scientists can add value towards the management of the patient. So it's always important that we work as a team. And in most countries, actually, when people are doing grand rounds every day or every week, the team is composed of medical lab scientists, pharmacists, infectious disease specialists, and clinicians working together to manage patients. So in medicine, teamwork is key.
There's been a lot of conspiracy theory around COVID-19. And I would like us to either debunk or justify this sentiment that it is a construct of someone in a lab somewhere, or it is indeed a genuine virus whose cryptic character we're all sort of trying to grapple and get our heads around. But of course, you guys being, again, the ones dealing with it and understanding its character and understanding its genomic makeup and everything that goes with it, I want to hear from you. Is this indeed a genuine virus, or do we think that someone's tampered around with science to just destabilize the world?
Before I answer that, I wanted to answer your earlier question around sort of how, as clinicians, we're accessing information and data, and just point out what's been very remarkable to me, so I'm both a clinician and a researcher, is that in the last 6 months, we've learned so much about this virus. It's pretty incredible how much we've learned, how much we thought we knew was right, and we've corrected ourselves, how much new biology, virology we're learning every day. And it's been pretty incredible that in such a short space of time, we've achieved things that took us years. I mean, if you think of, sort of early in the HIV epidemic, 6 months in, versus where we're in now, we probably could do some things more efficiently, but it's been pretty remarkable how much we have learned. And the information is filtering across. I mean, a few months ago, everyone was excited about, say, hydroxychloroquine. Even the virologists were telling us that, it really doesn't have great activity. And as clinicians, we felt we need to do something. We can't sort of sit and wait. And so, we're treating people with hydroxychloroquine. And then as the data came through, we realized, no, this is not the right thing to do, and moved on. And it's been pretty remarkable to sort of see that process happening fairly rapidly. Yes, it could be faster, but fairly rapidly. And to see how, as science and clinicians, we're working together, we're creating these massive clinical trials. So in the Zimbabwe context, things like the Solidarity trial, and rethinking how we're thinking about doing clinical trials so that we're much more efficient. Not every little person is doing their own study. We have good control groups, we have good protocols, good study design. So I think in many ways, this epidemic is forcing us to communicate much more rapidly, share ideas rapidly, implement, course correct more rapidly in a way that I think is quite positive and quite instructive. And then to get to your second question on this COVID lab-based thing, I can comment, and then you certainly have virologists on the team. So coronaviruses have been with humans for a very long time. So they're alpha and beta coronaviruses that are part of our sort of common cold virus population. Some of them entered into the human population a few hundred years ago. More recently have been new coronaviruses. In the last sort of about 20 years or so, we've experienced other coronaviruses that are new to humans. So things like MERS and SARS-CoV-1 and now SARS-CoV-2. And all of these have been zoonoses. So that means these are pathogens that exist in animals. So for example, in bats, and then need to be transferred to humans either directly or through some intermediate host. So for SARS-CoV-1, it probably was the civet cat. For SARS-CoV-2, we're still trying to understand what that intermediate host is. And just to say, SARS-CoV-2 is the cause of COVID-19. So if we look at the viruses, it is a real virus that's a zoonosis that has been introduced into the human population. And because it's new to us, it's not like all the other coronaviruses that we're used to. We've all had the common cold in the past, etc. It's completely new to humans. We have no immunity to it. And because we have no immunity to it, it is causing significant disease, and we're experiencing it through this epidemic at this time.
So David, I'm going to connect what Tariro said to you, if I may. I certainly am curious to understand about the advantageous mutations that get an illness such as COVID from an animal to a human being. But beyond that is this big issue around how we actually fight it. So yes, there've been buzz phrases and buzz medicines that have come onto the scene. So we've heard about hydrochloroquine. We know that dexamethasone is the next big thing. I read a report that pointed to an intravenous chlorine dioxide as a cure that's come out of Ecuador. So you've got all these people suggesting that actually we've got a solution for COVID. Is this something that should let us sleep more peacefully at night, or should you guys behind the scenes kind of continue to convince the world not to relax too quickly?
Well, what we're seeing in the US is, in fact, yes, it's a bad idea to relax too quickly, because 3 to 4 weeks later, you will see a big increase in cases. So I think Zimbabwe has followed a remarkably consistent course in not relaxing too much. It seems to be working, but we are suffering from an extraordinary lack of information, which I'd hope maybe someone would want to comment on, which is I have yet to hear, other than the sort of Zororo disaster, which kicked all this off, and then a number of elderly people who have been found to have died with COVID, whether there is any clinical disease in Zimbabwe at the moment. The daily reports we get of the positive tests tell us that this is still very, very isolated. There is not a lot of community spread, and there certainly is not a medical surge. How to maintain that and, in fact, function in the economic, social world, as well as Zimbabwe is I think, very important to figure out. But so far, I'm not sure the demand for medical care has in any way overwhelmed the system. So I think the information on how sick people are would be very, very useful. And that's not sort of forthcoming from the reports that we get from the Ministry of Health.
Okay. Anyone wanting to answer that? And I think for the most of us, actually, there's typically a concern that we're either not getting accurate information, or we're just super immune or have an advantage physically, biologically to COVID-19, which is why you're going to have more extreme cases in Italy versus what we see in a place like Zimbabwe. What's your take on that?
From the Zimbabwean perspective, I think we haven't yet been seeing a lot of clinical cases. It's not that there's underreporting, it's just that we are not seeing any much sick patients. Otherwise, if we were places like Parenyatwa and Wilkins Hospital would be full every day. Why it is like that, I'm not sure. It's something that we really need to investigate and try to identify. Maybe it can inform other people on what's happening in Zimbabwe. But right now, I can confidently say that there aren't as many clinical cases as people would expect.
And when COVID hit, I remember speaking to a few people of African descent, or indeed Africans, whose theory was that we only get struck by Ebola virus. COVID is too weak for our systems. And I know I can see Nyandoro viciously shaking her head here, but there have been a lot of misconceptions. And I suppose the stats coming out of places like Zimbabwe may actually reinforce this thinking. What would you say to that, Richard?
I mean, again, we're just learning. I mean, we still are only really hitting the tip of the iceberg in terms of what we understand about this virus and about the body's response to it, the immune response and things. And there's lots of very interesting observations around Africa as to different countries having different epidemics, and it's really not clear at the moment whether that's just that there have been fewer introductions into the country and fewer opportunities for the virus to really take hold and spread, or is there a difference in the host, in us, from our genetics, from our immune makeup? And that's some of the key research questions and things which people on this call will be looking at, because we're used to those kind of research questions around HIV, around TB, around other infections. And just going back to your question a couple of minutes ago, I think, as Nyandoro said, the science around this virus and this infection has been phenomenal in terms of the speed of the science being done, the quality of some of the science that's managed to happen during this pandemic. But there is also a lot of terrible science happening and a lot of fraudulent stuff going on. And so some of the things you mentioned with these cures that are immediately touted based on very little evidence at all, or very weak evidence, there are always going to be these people that take these opportunities, and that's very sad to see in a pandemic like this. But luckily, we have enough of the very, very good science, like the Solidarity trial that was mentioned, like the recovery trial that's happened in the UK, that's giving us all this really high quality evidence in the middle of a pandemic. And we need to focus on that and doing the right research in those environments, mm-hmm. to treatments and the vaccines and the other things we need to deal with this infection.
So talking to treatment and vaccines, again, thinking as a layman who would have made an observation that, HIV/AIDS has been around for about 40 years or so. We haven't had a vaccine, a cure for that. MERS, SARS, again, big ticket illnesses that we would have thought science might have come up with a solution for, and we've not seen that come through. What would be different with COVID-19 to give us any assurances that these timelines of 18 to 24 months for a vaccine could realistically be achieved?
I mean, again, I'm not a virologist, but from a simplistic view from me, it's a much simpler virus than HIV, and the immune response may also be simpler. So compared to HIV, there's no reason that it won't be quicker than the development of a vaccine for HIV. And when you mentioned SARS and MERS, the reality there was that the SARS epidemic was controlled within a few months. And so there was no incentive to continue development of a vaccine. And the people that fund research and fund vaccine development are not going to fund something if the disease has disappeared. And similarly with MERS, it still grumbles on, but it's not become a global pandemic and a huge problem. So again, getting money to do the research around that is difficult for researchers. And here there's clearly going to be a much more concerted global effort to develop vaccines because of the global need for it.
But don't you feel as scientists that it's irresponsible for governments to wait until it becomes a global issue before they start funding some of these trials? I come back to Ebola virus, for instance, where when it was localized to West Africa, it was an African issue. So the funding just simply wasn't available. At the point that it breaks across African borders, you start seeing a bit more of a sense of urgency, and lo and behold, the vaccine comes up. So when you're thinking about these patterns, again, as people who don't have access to science other than what we read on the news in articles, research papers, and so forth, do you find as a science community that you're really pushing and advocating for a more proactive approach to finding solutions to illnesses such as COVID?
I just think we've left out a key, and Justin brought this up right away, that in fact, the social organizational response to COVID has been so wildly variable in our case, in the US, each state, county, and city adopting different approaches. And what we get to see in more or less real time is what happens when you implement a lockdown and then when you release the lockdown. And that experiment is going on in 193 countries, and the sub areas, all epidemiology is local. But I think how we can learn from the experiments going on in every village and hamlet. And that's why I'm particularly interested in Richard helping us understand how the South African response, which includes sending everyone with COVID to Zimbabwe, how that is impacting how that is impacting the control and mitigation methods, because I think South Africa took a very reasonable set of measures. I'm not sure kicking out everyone with the inappropriate visa status was necessarily good for Zimbabwe, but how is South Africa dealing with the surge? Because that's what I gather we are all preparing for. And while it's lovely to talk about large randomized controlled trials of drugs, which will likely not be available for quite some time and can only be administered, intravenously, I think the very simple social distancing measures that appear to be adapted are doing a lot of good at the moment. That's not to say we shouldn't prepare, but frankly, I think those are the really important decisions that the decision makers, the policymakers, are wrestling with on a continuing basis, and what we can do to inform them, looking at both regional and global things, are what fascinate me. Mm-hmm. So I'd be interested, as much as it's fun to speculate about vaccines, and Tariro and I have been talking about that in California as we both are in isolation. I'm very interested in how South Africa thinks they are going to chart the way forward around their surge as well as re-lockdown.
So Tariro, I'm going to come to you first, and then let's circle back to this question on transfers from South Africa to Zim, and indeed the caseload in South Africa itself. Tariro, you wanted to say something about my previous question?
Sure, I wanted to say something about a couple of things. So the first, and why I was shaking my head sort of around the question of, is Africa different? Are our immunities different? Why are we not getting as many cases? And there's been a lot of speculation around this. And I think that Richard sort of pointed it out clearly, and I just want to emphasize that. So at this point in time, there's no data to suggest that we are any different from anybody else. And certainly as Zimbabweans, we've seen, many of our fellow Zimbabweans in the diaspora get sick and die with COVID. So we do really need to do research to better understand that, better understand what the immunology aspects might be, to better understand if it is all demographics related. Are people getting sick and having mild disease? Because my guess is we're definitely not testing enough, and so we don't know that. And I think the other key thing is that we've implemented some public health strategies that may be helping. One thing that's a fact is, Zimbabwe is not a hub of travel, of tourism. So there's not much introduction. I think for Africa, a lot of it has been imported cases of starting the process. We haven't had that much introduction. It might change, as David pointed out, as people are being returned from South Africa. So I think we should be cautious of having a surge due to that. But I think we should not think we're exceptional. In fact, we should think that, like all humans, we are as susceptible and what are the key things we need to put in place to minimize the risk of spread, as well as think about the economic consequences as well. So it's a pretty complex question, but I think we should avoid thinking that we're that different from everyone else. We might have some advantages with our demographics, but at least physiologically at this point, there's nothing to suggest that we're different.
Is there any mileage in this theory that the BCG jabs might give us an upper hand?
So from the data that I've seen,
that was an emphatic no.
I mean, the data I've seen from the BCG stuff is purely correlative and just really not great quality data. So I would not hang my hat on the BCG stuff. There are studies, there are a few studies that are planned to vaccinate healthcare workers, etc. That data will come out. But there's really absolutely, at this point, correlative data that is highly flawed. So the answer is simply no.
So I'm going to pass the co-hosting mic to Darlington because he's sitting quietly observing, and I know that you've got loads of questions that you probably want to ask. So you've got an opportunity, Darlington, to jump in with a question for any of the panelists.
Oh, good. My one question is this. We're seeing the spike in the States jump up real high in the last kind of couple of weeks. And there's a lot of talk about, there's increased testing. Would that be the correct answer to that? Because you wonder if there's increased testing, but there is the disease or the virus is not spreading that much, then obviously increased testing would find less people. But there is a lot of talk about increased testing. I was watching just today that one of the Dallas officials rebutting this issue about how the social distancing hasn't been very good in that part of the world, and that was causing the increase in the cases. So I'd like to hear from these guys what they feel. Is it an issue of testing, or is it an issue that the social distancing guidelines have been released too early?
And then Richard, if you could tag perhaps your answer to the big question about South Africa as well.
The United States we're number one. That's really, that's Trump's dream. Unfortunately, it's number one in both death and cases. I think what people in the United States are now advocating, including Fauci just yesterday, is yes, in fact, doing low-cost pooled testing on a regular basis is the only way you're going to really know what's going on in the community. That we've focused on in Zimbabwe, focused entirely on deportees returning from South Africa, but there has not been any attempt to find out, is there any COVID in the community that in fact warrants the kind of social distancing, which has been largely implemented, but sort of in a haphazard way, I dare say. I think that actually the strategy in Zimbabwe is working, but I'd really like to see serious testing go on in hopefully a cost-effective way. So this gets back to how do you open the schools in a way that allows people great deal of security in sending their children to school, the teachers in going to school. That's the immediate social problem, I think, that is facing most people in Zimbabwe. And I don't see a more effective way than to implement some kind of comfortable testing that can be done cheaply. And I think that's what Justin and a number of other people throughout the world are working on, which is how do you pool these tests in a way to reduce the costs to the point where you can do it regularly. This is sort of slowly being realized by communities that are trying to reopen and realize they made a big mistake in the US and they're now shutting back down again. And this kind of fluctuating on and off lockdown is not a very efficient way of dealing with a pandemic. So the US is showing the remarkable inefficiency of sort of responding politically to these questions. But I'd really be interested in what everyone else thinks we ought to be implementing in the short term with the technology that we have to assure people that you can selectively reopen those parts of society which you think are very important. I'm really struck by the importance of children getting an education that prepares them for their future. And I think there is something about school as a socializing factor that we've all gone through that we shouldn't be depriving young people of if we have a safe way of doing it.
So that's a multi-tiered question. I would actually like to focus on the South African, the repatriation of Zimbabweans back. Justin, this one's for you. What is your gut on this? Yes, people want to come home, but if every time you come home, we've got multipliers of the caseloads, what do we do? How do we make that work?
The repatriation of people, I think, is it's an economic issue, and unfortunately, there's no way we can let people just stay in South Africa when they are not economically productive and if they really want to come back home. What we need to do this side is to make sure that we have enough resources to make sure that people are tested sufficiently, and if we're going to have quarantine facilities, they should be designed appropriately to even also prevent infection during the quarantine facilities. And I think the quarantine should be done at towards the points of entry instead of busing people, because busing people also it's an opportunity for other infections. So for me, we need to make sure that we, as a Zimbabwe, we are ready to make sure that we test our people when they come back, when they're coming back, and we also prevent infections in transit as much as possible.
Okay, and Richard, I saw some reports on the state of hospitals in the Western Cape in South Africa where systems are crumbling because they can't deal with the caseload. Given the close proximity between South Africa and Zim, how is it that you've had such a surge of cases in SA? And yes, it's a large tourist site, but at the point that borders closed, I don't believe there would have been that much of foreigners coming through and potentially bringing the virus with them. What's happened in SA?
So I think it was less foreigners bringing the virus in as returning South Africans bringing the virus back. So I think that we almost certainly had a lot of imported infections in South Africans who had been traveling in holidaying or on business in Europe at the time when the epidemic was really accelerating in Europe. And I think what we've then seen is that we had a very early lockdown, and I think we got a little bit complacent then, that we were congratulating ourselves that we'd managed to slow the rate of growth of the epidemic. And now, as we've eased out of the lockdown, we've seen what every other country has seen. We've seen this accelerated growth of the epidemic. And we've seen it very much similar to other places. We've seen it's not homogeneous around the country. It's still largely centered on the big cities. And we've seen this very kind of heavily clustered growth of the epidemic. So we see clustered outbreaks in hospitals, in big workplaces, factories. We've seen it in the mines. We've seen it in the prisons. We're starting to see it in the schools. And our university is just reopening. I'm going to see it in our university pretty soon. And we're in a really worrying situation now, because I think there's very little appetite to go back to a very hard lockdown. And the feeling that even if that was the directive, that the adherence to the hard lockdown may not be as good as the first time round. And the health system is severely stretched in some of the different provinces. In KwaZulu-Natal, we are a little bit behind the other provinces of Western Cape, Eastern Cape, Gauteng at the moment. But we are starting to just see the acceleration now. And so very worried. And I think this point about movement of people is really important. And I think that's one of the things that worries me within South Africa, is that because the provinces are moving at different speeds and at different times, what we're going to see is movement between the provinces. So we're already seeing in Durban, a lot of people have come up from Eastern Cape, because the Eastern Cape hospitals were starting to become overwhelmed. So people instead have come up to Durban, are now in intensive care in Durban. We're going to see similar movement now from Gauteng. And then the opposite will happen as these provinces come out of the first kind of wave. And that's a real worry, because you'll get continuous seeding of new transmission chains. And I think the broader point is then that if the borders are porous, then this can also happen between African countries. And that's a real concern, definitely.
And Darlington, when you hear this, given the work that you're doing with hospitals in Zim, do you think that we're prepared? So for all the investment that there's been through SOTZIM, collaboration with the state and so forth, how ready are we for a severe outbreak?
Well, Mucha, we've been battling, trying to stay ahead of the virus, if I want to use that statement, because for us, if we have an onslaught, just a small little onslaught, then we're going to be in trouble, because what happens is that the number of places, the hospitals that you can say that are going to be ready for treatment, especially of clinically bad cases, there's an 80 bed here, 30 bed there, 100 bed there. But if you've got a serious onslaught, then we are going to have a challenge to handle these cases. Like Justin said, the fact that we've been very mildly affected so far has almost been like a godsend that to give us a chance to prepare. But we were in Bulawayo last week, and I can tell you the big hospitals there are not ready. We are working with Equisileni, which is pushing as hard as they can. And, I marvel at the work that the guys are doing there. But if they needed to open tomorrow, they're probably 5 to 6 weeks away before they can say they can take a patient. At St. Anne's, we're probably a week or two away before we can take patients. There's another hospital I'm hearing in Harare that's an 80 bed that's just come along recently that says that it could be ready by end of this week, maybe next week. But those beds are just not enough. Justin, I can see Justin smiling, and I'm assuming he's concurring with my statements, but I just don't think we're ready enough. If we just continue to pray that we don't get hit by an onslaught, especially the one they're experiencing in South Africa. If we had even half that, we'll be in trouble.
And Justin, given how emphatically you're nodding your head behind the scenes, I've been wondering, there's been a curiosity to understand who case 0 was, right? So patient 0 in China, we don't really have much information about how COVID jumped into his system and how he or she became the catalyst for what 2020 has become. When you start hearing these sorts of concerns about Zim and its preparedness for COVID-19, and you've got front row seats to the character of COVID and how it mutates and how destructive it can be. I read a report that alludes to the fact that this is probably one of the cleverest viruses. It's very elusive, and at the point that you think you understand it, it finds its way of masking itself in the body. So people go for these 2-week periods without necessarily knowing that they have it, and then Tara was frowning. Really, I read a report. There's a lot of stuff out there, right?
I think you're alluding to something which happened very early in this pandemic, which was the assumption that that symptoms were the problem. And that's the worm that is turning just now, that people are realizing that probably more than half of the people who get infected don't even know it, and that they are then capable, and the term super spreader has been used, the term asymptomatic, and these huge debates about, well, what is asymptomatic exactly? But I think you get around to the inevitable conclusion that the only way to find the virus and to isolate people appropriately is to do larger scale testing than we have been prepared to do. Sure. Lots of countries are wrestling with how to go about that, but I think Zimbabwean ingenuity should be brought to bear on this question of how can we allow workplaces to reopen, but in fact test fairly frequently. And there's been this huge barrier that, this is $65 a pop. There's no way to do that on a large scale. I think what sort of modern technology is indicating is that this can be reduced to a few dollars a pop when your prevalence is very low. And we are in that fortunate situation where the prevalence is extremely low, I believe, although no one has thus far done the experiment to show that. But I think we'd really like to do that, because in fact, that's the point when you can apply this pooled testing with nasal turbinate swabs of people in the community to in fact say who can safely bubble with one another, who can be a school in which the kids can go to school, the parents can feel comfortable. But because prevention is really so much easier than cure or treatment, I think Darlington is pointing out that treatment at the scale that has been taken on by whether it's Gauteng or Cape Town or soon to be Durban, and they're preparing in Bulawayo, is a very expensive and probably not very feasible activity in a country that has very limited resources.
Thank you for neutralizing Terry Rose's frown by providing that context.
Before completely neutralizing, I do want to point out a couple of things. So this virus is very interesting in that it's a very large virus, but it's an RNA virus. And so RNA viruses like HIV are error prone. So they make mistakes when they replicate. And HIV doesn't have a proofreading capability, whereas this virus does. So it's actually a lot more stable than HIV is. One of the biggest challenges with HIV is that it just keeps mutating and mutating, and most of the virions don't survive, but it doesn't matter because if you mutate enough, some of them will survive. Whereas this virus is an RNA virus, just similar, I don't want to say similar to HIV so people misunderstand, but it's also an RNA virus, but it has a proofreading capability. And so we haven't seen as much mutation. There are some variants that have come out, but it's clearly nowhere near as variable as HIV or even HCV. That's something just to clarify for folks. Then to just lastly comment on the testing and the question that Darlington raised around testing for the US. So testing, yes, certainly will increase your numbers, but the really important thing to look at is what the positivity rate is, because that gives you an idea of whether or not you're testing enough and whether or not you're getting high enough cases. So the positivity rate is going up just as the testing is going up. So suggesting that, we're still testing people who are presenting with symptoms. We're not yet out to testing everybody, because if you were testing everybody, you should have a lower positivity rate. But in addition, given that that rate is going up, it means that more and more people are sick and are acquiring the disease. I think the biggest challenge in the US is that the restart happened before cases truly came down. We're still having 18 to 20,000 cases per day as a country when people lifted lockdown conditions. In individual states, cases were rising, so people weren't even following the basic guidelines around making sure cases were dropping before opening up. So what we're seeing is inevitable. I mean, if you're a basic epidemiologist, you're not surprised that we're seeing the surge that we're seeing, because the virus simply needs a body to infect. And as David pointed out, what we're learning about this virus is you don't need symptoms. There's been beautiful studies showing that people have high viral copies even when they're asymptomatic. So they're still transmitting while not knowing that they have symptoms. And in that scenario, you can just see how a virus rapidly escalates in a population if you don't take on the right public health measures to mitigate and reduce the spread.
So Tara, I suppose that supports this theory then that it is quite an intelligent virus, but I'll park that there.
Well, all viruses are intelligent. All viruses are intelligent viruses.
So who's going to win, science or COVID? We wait to see this. Karen, you might have a couple of questions for our doctors as you start to consider rounding up.
So I wanted to ask, first of all, Richard, the deaths that we've seen in South Africa, we've had a number of deaths, quite a large number of deaths, but they've not given a breakdown. What is the age groups? What are the stats surrounding the numbers of deaths? That's the first question. And secondly, would you say that South Africa is now, the spread is community? It has now become a community spread, because we've not had that in Zimbabwe yet. Well, I don't, correct me if I'm wrong, but it's very interesting for me that we're not seeing the statistics or the breakdown of the fatalities in South Africa.
So I answer this a bit in reverse. So yes, we have community spread, but I think that the point I made a little earlier was that even though we say community spread, we don't mean it's in every community, and we don't mean it's spreading widely across the whole country. it's still kind of localized to certain areas. And in the Western Cape, it was obviously largely localized to the poorer communities in high density townships. So where that physical distancing is very challenging, both inside and outside your home. And in terms of the deaths, yeah, we're now getting close to 3,000 deaths. And the Department of Health does produce some breakdown of the deaths. And there's been some analysis of the data, both from the Western Cape and the kind of national data. And we see the similar patterns to what's been seen elsewhere, that age is the major factor in determining whether you're going to die with COVID. So the age over 60 is still the group that is most at risk of death. And then we're seeing the other factors come into play. And the two big ones, I think, that have been seen in the Western Cape are obesity and diabetes. And obviously those two often go hand in hand, obesity and diabetes. We haven't seen, and the data from the Western Cape so far, we haven't seen a big effect of HIV. And obviously that was one of the big concerns for us in South Africa and Africa more generally, was would HIV make this disease worse? Would it increase the risk of death? And we're not really seeing that it's having a profound effect. And that's one encouraging sign from this. So largely age, diabetes, obesity is kind of driving the mortality in South Africa. Would it be fair to say Zimbabwe has much lower levels of obesity than South Africa? I would.
Yeah, I think so.
Definitely. Definitely. I think we don't have that much spending power for fast food like they do. We eat a very natural, healthy diet on the whole. And people tend to exercise a lot more in terms of walking. People walk a lot in Zimbabwe. So obesity, no, but diabetes is quite prevalent in Zimbabwe. And then the other question that I was going to ask is, for example, in Zimbabwe, when people get tested, there's a lot of stigma surrounding testing. So people will try to avoid being tested, because if they get tested, then it's like they've got the plague. Or, for example, if they do get tested and it's negative, they get a false sense of, I'm fine. I can now go with no mask and just go out there and do my thing. And, so there's definitely positives and negatives to testing. That's from the perspective of the communities and the people that I interact with. I don't know about everywhere else.
Well, if I could just answer your age-related question quickly. When the lockdown was reversed and testing was increased, the age of people with symptoms declined from a median of over 60 to a median of something in the high 30s very rapidly. And so that tells you exactly what happens. It doesn't impact the deaths, or it won't for some time. But it does tell you that spread with the sudden unlocking or premature unlocking really resulted in a big shift in who was experiencing symptoms and therefore who was tested. So the original sin, which is, oh, you only need a test if you're sick, creates a sort of ongoing false sense of security. And in fact, that stigma that you're talking about with testing, which probably is left over from the HIV phenomena, will in fact, dampen our ability to know who really could potentially cause these brush fires in the community, which we fear, but have not yet really happened. So I think testing is something that could really keep Zimbabwe safe, but I'm hesitant to recommend it only because it seems to be attached to a great deal of the stigma.
I think testing is fantastic, but do we actually have the resource to process the results in real time and in a meaningful way?
We've been working very hard to make sure that we have the resources. I think the government and a lot of its partners have come on board to try and mobilize resources to make sure that testing happens. But there are still challenges here and there, and that's why we've been advocating for pooling strategies that will reduce the cost, because these kids are expensive, and we are in a very economically challenging situation, and we need to make sure that we use our resources optimally and so that we can be able to test more people. But in terms of the labs themselves that are testing, I think we have a very comprehensive strategy in terms of how we can upscale testing from the central lab, which was the National Microbiology Reference Lab, to a number of academic and private sector labs that are supporting the ministry in terms of testing. All our provincial labs, I think, now have capacity to test, and most of our district hospitals that have gene expert machines also have a capacity to test. So in terms of the lab side of things, I think we have structures in place that can be able to support, as long as we mobilize the resources to ensure that the test kits are available, the swabs are available, and the transport medium or the cell line is available to make sure that we sample as many people as possible and test them efficiently.
So I'm going to feed into a stereotype that suggests scientists would prefer to be in labs or dealing with diseases than talking, by observing the time where we've kind of passed our hour. I did want to lighten things up a little bit by asking you all what your favorite virus is. What's your favorite virus and why?
I like retroviruses, especially HIV, because from HIV we have learned a lot about evolution of viruses. HIV, because of the rate it evolves, it's very difficult to make a vaccine for, compared to, for example, SARS-CoV-2, which if really we work very hard, we might be able to get a vaccine because of its stability. So for me, I like challenging viruses, and HIV has been very, very challenging for us. And that's why I work on HIV, and I think I'm going to working on HIV for a few more years. Yeah.
And then Tariro, have you grown out of malaria, or have you still kind of got your initial fixation?
So I've not grown out of any infectious diseases. I'm an infectious disease physician, so love it all, whether it's Staph aureus or COVID. I would like, if I could, just answer a few things and make some key public service announcements, I think. So the age factor, yes, age is important, but I've been taking care of patients in the ICU who are my age, so 40 and 50 or younger, and people are really sick. So it's so important for people not to think that this is an old people's disease. This is, I think I'm young, can be a very severe young people's disease as well. And it can be a very complicated disease to have. So young people is so important to be engaged in protecting yourself as well as protecting the community. Yes, mortality is higher in older people, but there's still significant morbidity in young people as well. Then the second, the stigma piece. I've worked in Zimbabwe on HIV for ages, and I think that some of the stigma is carrying over from HIV. This is nothing like HIV. First of all, we shouldn't have stigma against HIV at all. Any of us could be infected with HIV. It doesn't make you any less of a person. There's good treatments, etc. But more so with this disease, it's an acute illness. It will come and it will go. Most of us will get infected at some point or another. So please get tested so you can protect your families and your community. And let's not attach any stigma to this whatsoever. And then the last thing I would like to say, there's so much I could have said on vaccines, et cetera, et cetera. But the last thing I'd like to say is, in terms of answering your question on favorite viruses, I made the mistake of giving viruses a human quality, that they're all intelligent. And granted, I'm a human, so I see things in human eyes. But viruses are really fascinating machines. That have the capability of doing things that, affect individuals, affect societies, and affect communities. My personal interest remains heavily in HIV, though certainly also working on COVID. And I think the nice thing about all of these viruses is what we've learned from one has really helped us learn a lot for the next virus. So a lot of the people working on COVID vaccines worked on HIV vaccines. A lot of people working on nucleoside inhibitors for polymerase and COVID or protease, etc., worked on hepatitis C, worked on HIV. So all of the viruses are fascinating, and really sort of have helped us deal with new emerging viruses in meaningful ways.
Terry, I've come to rely on you for getting to the bottom line really quickly. You successfully talked yourself out of your last remarks. I'll have you know that. But thank you very much for that. Could I please know what your favorite virus is, Richard?
I don't have a strong favorite.
No?
Chikungunya virus, just because I love saying chikungunya. I love the word. So
The one that we've all never heard of before.
Exactly. So that's a good choice. So you don't know if I'm saying it right.
Right. And then David, over to you.
I was going to invoke a very important infectious disease in rabbits, because I know how attached Justin is to his rabbits. And there is a disease caused by Bordetella bronchoseptica, a bacteria, not a virus, called snuffles, which he must be constantly on the alert for given his population.
Got it. Thank you very much. And then to Darlington and Karen, which ones do you fear the most, or do you worry about the most?
Mine, actually, my favorite virus is people. You know, when you when you're trying to find them, they're not difficult to find, and when you're trying to sort them out, they're easy to sort out. So, but I think influenza. It's easy. You know, we get it. It's kind of regular. It's kind of and you can, you know, it comes and goes.
We're talking influenza or man flu, because there's a big difference between the two.
I think influenza.
Gotcha. Karen, what about you?
Well, maybe malaria. Is malaria a virus? It's not. Malaria is a disease. I don't like any viruses except, you know, all viruses. We need to just get rid of all of them. That would be my first. That would be the one thing that I would love to see happen.
And that's why we've got all these scientists to help us do that, don't we?
But before they go away, Mucha, we really need to know about vaccine. We really need to know that, for example, if today there was going to be a vaccine, what would give you confidence that that vaccine you would give to your child, or to your mother, or to your brother, or to yourself? Any of you scientists who are out there, what steps would have had to have gone through for you to accept that vaccine?
So I'm going to respond to this, and sorry to jump in, because I think this is really, really important. So vaccines have been perhaps the greatest invention of mankind in the last 150 plus years. The biggest impact in human health has been from vaccines, and they have been tremendous. I mean, we don't have smallpox anymore. We don't have measles anymore unless people don't vaccinate. And measles is an awful disease when folks don't vaccinate. And over the years, we have learned how to develop vaccines well. And we've also faced challenges in developing vaccines. So every vaccine that will be developed, so right now there's almost 200 different vaccine efforts for COVID, and almost a dozen or so that are in clinical trials. All of them will go through the standard processes of clinical trials. So, you know, phase 1 is simply asking, is the vaccine safe? And you do that in a small subset of individuals and determine safety. So you'll hear news reports of different companies kind of releasing their phase 1 data, and that's the first safety component. Phase 2, you're expanding on that safety and thinking about efficacy. So now you enroll a lot more individuals into the study. And again, you're looking at safety and starting to get some signals of efficacy. Then phase 3, even larger studies. You know, people are talking about thousands of people, tens of thousands of people studies. You continue to evaluate safety, but you're now starting to evaluate efficacy as well. And no vaccine that's going to be approved will not have gone through those various stages of evaluation. So I think the first thing to say to folks is, yes, we're trying to accelerate. 18 months to a vaccine will be incredible. We haven't done that as humans at all before. If we can achieve that, that will be amazing. But we're not going to shortcut on evaluating safety. So the vaccines that will be approved will have gone through the standard safety protocols. However, there are some things that we cannot predict, and these studies will help us further understand. So for example, there early attempts to make a vaccine against a virus called RSV, which causes the common cold, but in babies can lead to high mortality. Early studies of that vaccine in the 1960s made people aware of this phenomenon of antibody-dependent enhancement. So they are things that could come up that we'll only better understand as time evolves. However, all the vaccines that will be approved, because we do see people being very anxious about getting vaccines, will go through the standard processes of evaluating vaccines. It's on an accelerated timeline because we have an epidemic and you can rapidly enroll 30,000 people, et cetera, to try and get to an efficacy question. Once vaccines become available, those that will be approved will have been evaluated for safety. So I do want to allay people's concerns as much as we can, that this accelerated timeline doesn't mean that we're taking shortcuts. We're still doing the same things that we would do for any other vaccine that has been approved, and certainly we're always learning. So I wouldn't say that everything is 110% efficacious, and safe. But we are doing all the things that we usually do to ensure safety.
So in the absence of a vaccine, an approved one at least, or while the process is still ongoing, and I will come back to you, Richard, should we be concerned about the shoring up of remdesivir as that interim solution? We know that there's a medicine on the market that could be a game changer, but the States has just gone and hogged it all. Is that something we should worry about?
I would not put much faith in that
Really?
as a means of dealing with the epidemic.
Okay, why?
Well, the data we have on remdesivir says that it can shorten a long hospital stay and potentially get people off of ventilators, but actually did not change the mortality. So we're dealing with a downstream effect of a very bad epidemic in which an expensive intravenous solution may in fact result in an earlier discharge from hospital of exactly 4 days in carefully randomized controlled trials. So how relevant that's, if I were very, very ill, I would want it. On the other hand, as a country which is now facing the onslaught of an epidemic, it's not likely to offer very much.
That is most informative. I know you wanted to say something, Richard. Could we make it?
Yeah, short. So
yeah.
I agree completely with David. We certainly shouldn't call remdesivir a game changer because there's very little evidence that it's going to impact on transmission of the virus, and that's what we need. But I just wanted to emphasize, just to add to Teriro's point, the other critical thing is that we are doing the vaccine research here in Africa. It's so that we do the science here and we understand whether the vaccines are going to work in our populations, and we build the capacity to do this. And one of the encouraging things this week is that we started the first vaccine trial here in South Africa with the Oxford candidate vaccine. And we're kind of building on the HIV vaccine trial network to build up COVID vaccine trials. But on the contrary, today was really worrying because we saw that there were protests outside the trial sites for this vaccine trials, with a number of people protesting that this trial shouldn't be happening because we're experimenting on poor Africans. And this is what's come up before with HIV vaccine research and other interventions. And we've got to counter that, and we've got to make it clear that it's a good thing that the vaccine research is done here, and we must encourage that.
I do wonder though, it's all fair and fine to be that science center where these experiments are being held out, but I do speak in defense of the continent in the sense that we're there sometimes, or at least the perception can be that we're there as guinea pigs at the point that something is FDA approved and has hit the market, we're excluded from that market because we either can't afford the medication or it's just not readily available for whatever reason. So food for thought on that one.
That was the same thing which prevented people in Africa from getting antiretroviral therapy for probably 5 to 10 years. So I think we need to learn from the lessons of the past that,
sure,
yes, it's very good to be cautious, but on the other hand, as Tariro indicated, vaccines have been our best long-term solution to epidemic viral diseases. The anxiety that somehow experiments are being done whether you're using a vaccine or not, because each one of these attempts at lockdown, attempts at reopening is in fact a large-scale social experiment that sometimes, in fact, inevitably results in tragic consequences.
And whilst there's no question, at least in my mind, about the importance of vaccines, I think it's more a question of the equity of that distribution of testing, and that tends to be the contentious point.
I think if I could just add, Muchayeva, because I think this is a really important point for science in general. I think the anxieties are very valid. I think the anxieties among Africans, among Black populations, on science and research and how it directly impacts our communities is very valid. We can just look at the Tuskegee experiments and the racialization of research throughout history. So these anxieties are not totally irrational. They are based on a historic fact. I think, though, what has happened is the recognition that these things have happened and putting in place policies and procedures that minimize that kind of activity taking place, so that we are not guinea pigs. As Africans, we're not guinea pigs or just experimental components of studies. We're part of a global scientific community that recognizes bad things happened in the past. Bad things could happen again if you don't have the right policies and procedures in place. But with the right policies and procedures in place, it's absolutely critical to be engaged in research. There are some countries, for example, in Asia, that will not approve a drug unless it's tested in their population to understand the efficacy and impact in their population. Similarly, we need to be involved in the research because we need to understand, do these vaccines work for us? And we also need to have this research conducted in our environments with our scientific leaders and our scientific communities, guiding and moving that research forward. But by saying, no, we don't want to be guinea pigs, we're acknowledging the historical past, but also preventing ourselves from engaging in the potential that therapeutics can have. What we should be saying is, yes, we will engage in the research, but do we have the right policies, procedures in place where we're not guinea pigs? We're learning, and we are, as Africans, participating in the development of therapeutics that will be useful for our populations.
So I'm not a scientist, but I absolutely agree with everything you've said. And as a layman, I do feel particularly passionate about this idea that, yes, take the testing to the Nordics or to largely Anglo-Saxon environments, and the same way that you'd be willing to do it in Ivory Coast or wherever. But that's just my take.
But the fact is that's exactly what's going on. So that's the other really important thing to educate people on. It's not that the studies are not happening in the US or Europe, they're only happening in Africa. The very first trials for the vaccine were in wealthy people in Seattle who were volunteering to be vaccinated. So we need to be engaged. We shouldn't always assume that everything is racialized. Many things are, but not always assume that it is. These studies are happening globally, and if we don't participate, we'll never know if they don't work in our populations. We have to participate at some point in time, and it's really important that the investigators also be Africans. It doesn't go down very well if all the investigators are white Americans, South Africans, Europeans, etc. It has to be very strong African component to it. It's how you build trust and how you get people to engage and be involved involved in these trials.
And I think, as we look to close, that I don't believe that the majority of people address these issues from a racial point per se. I think it's just about, as you're putting it in a historical context, and really perhaps the misinformation that is shared around the extent to which testing is happening in other geographies. But the reason we have these sorts of conversations is to tease these themes out and really gain an understanding of what's really going on. So thank you for clarifying that point. My very final request to everybody before we look to shut down, I know that Carol wants to talk as well in a few minutes, but could you just leave that one key message that everybody watching this show ought to walk away with and remember?
Okay, so for me, I'll just say, let's try to test as much as possible and try to identify people that are infected and give them the right support so that we can prevent further transmissions.
So just the theme that's really run through, don't get complacent that this virus isn't coming to Zimbabwe. Prepare. And that means on an individual basis, everybody should prepare for what they're going to do to prevent themselves getting infected and spreading to other people, and prepare as a health system and as communities.
I think we may be tired of social distancing. We may be tired of wearing masks. We may be tired of not visiting our elderly parents. But remember, the virus is not tired. So we need to continuously be alert to these things and continue testing.
If what you're doing is working, keep doing it.
I can't stress enough how important it is to remain vigilant and disciplined, Zimbabwe, in terms of wearing masks and the social distancing. I mean, I know all the staff who work with me get so frustrated because every week I keep saying, no, I think that you cannot go and visit your mom. Leave your mom, Kumusha. She's safe where she is. Don't take any kind of disease to her or your dad, etc. So we've got to remain vigilant. It's really, really important. I also wanted to say that Higher Life Foundation have brought in thousands of tests, and they have already started testing for free. I don't know if you've seen that, Justin. So that's a really positive thing. Strive and Sitsi Masiwa through Higher Life Foundation have brought in thousands of tests, a proper PCR tests. So hopefully we'll be able to test a lot more. And for those people who are coming home to Zimbabwe, don't forget to make sure that you've checked that all your details and so forth are correct before just arriving at the airport, because there's been some people who get to the airport and they're not able to come home because they don't have the right documentation. So check all of that. Write to us at SOTZIM or on our Facebook page or wherever it might be to get information. We're here to help. That's what we do. Thank you so much, Mucha, always for being such an incredible moderator and host. Thank you, Garai, and everybody at the back. Thank you to the 2019 numbers. Thank you to the donors and all our partners. We appreciate you, all the trustees, amazing people, selfless, and we really, really appreciate it. And I'm hoping that it's not going to be too much longer before we come to a close of the series, but we're just waiting to open the hospital, and then we'll be able to close. Mucha, don't get tired, please. Thank you once again. Over to you.
Thank you, Tarira. I haven't ignored you. You've given so many amazing nuggets through the show. So I am confident that most will be remembered. And I am being respectful of everybody's time on the show. I want to say a massive, massive thank you to the coolest profession in 2020. You guys are making such an impact and we all appreciate you. If we don't get to say it often enough, thank you. To everybody who's tuned in today, please join us again, same time next week on Make Your Mark with SOTZIM. A very good night to you all.